information regarding to the diagnostic. Why in orthodontic is important? For my points, is important because orthodontic treatment protocol is different and individual from patient to patient. Not like other field of dentistry, like filling or endo treatment. But here in orthodontic, all this information of patient is individual and cannot see one case, the treatment plan exactly for another case. Why? Because if you see class 2 cases, these class 2 cases, you can see in different overjet, you can see in different crowding, you different profile, you different lips, everything different. For this reason, you need to manage specific orthodontic treatment plan based on your diagnosis for individual cases. For this reason, to avoid the relapse and failing of the treatment, and also you don't get any problem during orthodontic treatment. And when you remove the braces later, you can see the stability of the teeth, no any relapse. This all based on diagnosis and what your treatment plan based on this diagnosis. Okay, everyone can hear me, is right?
Yes, doctor, it's very clear. Continue.
Hello? Yes.
Yes.
Okay. Now, before we start orthodontic treatment, full examination, including radiograph and assessment of the occlusion, needs to be carried out. Orthodontic diagnosis is important to evaluate and record malocclusion features for planning perfect orthodontic treatment needs, and also to avoid unwanted result of treatment. Orthodontic diagnosis protocol everywhere, if you go to different school in the world, European, everywhere, American, or also Middle East, you can see all go by this structure. Personal information of the patient complaint and motivation. Later I explain why this is important and what you need to take care for your diagnosis for these cases. Equipment, dental history and medical history, extraoral examination, intraoral examination. Now I try to share this information with you because majority I receive a lot of questions, but I try to share my experience in orthodontic as I start almost 1999 for orthodontic practice. And I try to share this experience with you, and later maybe we can share also from every participant if we have chatting. Okay, this actually personal information, name, age, address, phone number, this you need to take because this your relation with the patient will be for 1 year and more. Okay, patient complaint and motivation. Here, very important. In this clinical form, you must to write the patient complaint and opinion. Don't write in your language. Always I discuss with my students, don't write in your language. In patient complaint, try to write what the patient is worried. And in this area especially, try to write in his language, not in your language. This at least you know why this patient come to your clinic and what he needs from you. This first. Second, also you need to know which type of the patient he prefers. Is he come for fixed appliance or removal appliance? Sometimes he came only for fixed appliance, and you can see this simple case, mild crowding or mild malocclusion. We go for removal appliance, but he don't like this one. He is not cooperative. For this reason, this part of complaint you need to write based on his language, why he came to your clinic, and this one. After that, if you can see his reason, not that value, try to discuss with him to change his mind, but you need to work for this one. But in the beginning, you need to know why he came to you. This will help you in the end of treatment. Okay, motivation. Actually, patient motivation, we have two types of motivation. We have internal motivation, we have external motivation. This you need to write in form in details. What's the meaning internal motivation? What's the meaning external motivation? Internal motivation, he came by himself. External motivation, he came by force of parents, father or mother. For this reason, this many specialist clinic, they don't take care for these points. These points for diagnosis and treatment very important. Why? If the patient is internal motivation, he will be more cooperative in treatment. If his external motivation is by mother or father or brother force him to do orthodontic, he cannot do any problems with his family. He tried to create problem for you. For this reason, when you write the motivation, you can easily understand during treatment how the successfully. Sometimes he tried to lose the removal appliance. Sometimes no progress. This progress, no progress, because why? Because he don't wear this orthodontic appliance. For this reason, you need to write at least in during treatment, you know, this one he's interested or not interested. But if his internal motivation is will be good result and nice for you for cooperation. But if external, you try to work with this patient to make him more interesting and more internal motivation. Okay, let's we move to equipment. Of course, you need to take study model. This study model is record of the case before you start any extraction, before you start any treatment, you need to take study model. And this study model is record for you to protect you if the patient said after 1 year no different in result. At least you have evidence. And also, this one help you in choose the size of band in fixed appliance, because if you don't have study model, you cannot choose the perfect band. If you choose the band directly in mouth, this means your set in the clinic will be contaminated. Okay, now here everyone can see this X-ray.
Yes, doctor.
Yes.
Yes.
Okay, here. Okay, panoramic. This one now we move to equipment. Panoramic, every patient before you start any extraction, before you start any plan, before you start any things, you need to do study model and panoramic. Some cases, cephalometric also. Later I explain when you need to take cephalometric is compulsory. Okay, now this panoramic X-ray, what you need to check here, you need to check all the borders of the mandible here. You can see my mouse. And also you need to check the border of the condyle, is the situation of the condyle how, and TMG here, how is the anterior located, the posterior located, or is normal, as I see here is normal. Here the mandibular notch, here's the chronoid process. After that you check the bone, all the bone of the mandible, of the bone of the maxilla, to see if they have any pathology or any porosity or porosity of the bone, osteoporosis bone, osteoporosis of the bone. Need to check if you have any disease of the bone, especially osteoporosis. After that, you need to check also nasal septum here. You need to check the sinus, maxillary sinus, if they have any inflammation of sinusitis. Because sinusitis is easy to differentiate pain between teeth and sinusitis. Always pain of the sinusitis migrate in this area of our area because related to our molars and premolars of the maxilla. For this reason, all this need to check: temporomandibular joint, maxillary sinus, septum, condyle, the situation of the bone. Of course, in mixed dentation, you need to check also the eruption. All these things you need to check in details. Any indicated for orthodontic. For this reason, to be in my clinic now, some of patients, they came and during the treatment, they have mobility of the teeth. But the doctor, because he make the fixed appliance without any diagnosis, for this reason, in the middle of the treatment, already cannot improve anything. Because if the bone is not healthy, you cannot make the theory of movement of the teeth. For this reason, you need to check everything in details to get perfect result. If you don't go in details, believe me, in the middle of treatment, you cannot do anything. And also, to make your name in orthodontic is good, you try to choose your patient. If he is not indicated, don't take, because you cannot get nice result. This based on diagnosis. For this reason, I try to give you summary. I don't go for more details for all these diagnoses one by one. Okay, lateral cephalometric radiograph indicated for skeletal discrepancies and anterior posterior position of the teeth. This one actually, majority of clinic, they don't take for every patient. Also, if the patient is in panoramic is normal and his class 1 relationship of skeletal, sometimes we don't take of lateral cephalometric. But if skeletal relationship of maxilla and mandible, here you must do cephalometric. Actually, cephalometric, you can see here the cephalometric, check all is the mandibular, but cephalometric is lateral. You can check only anterior, posterior, or sagittal relationship of the our maxilla with cranial base and mandible with maxilla. Okay, here you can see the cephalometric. You can see here is the anterior cranial base. This is actually our frontal bone. This one is the nasal bone, is this orbital margin. And if you see here, this is the internal surface of frontal bone. Go down, this is la cirla torsica, where our point S in cephalometric, you can see this point S here. After that, you go down for tracing, and this one is the area of middle cranial base and posterior cranial base. After that, go up, and here is the articularis. Point is articularis, we call articularis. Of course, this is the ramus, and this one is point A, and this is point P, is the deepest of maxilla, and this one is the deepest of mandible. And this one, if you see the sharp here, the bone sharp here, is anterior nasal spine. And this one is the end of maxilla, is posterior nasal spine. And this structure, if you see, look like vinaigrette. This one is maxillofacial, batrego-maxillary feature. And this one, batrego-maxillary feature, give you guide of point posterior nasal spine. Because the length of maxilla from this point, anterior nasal spine, to posterior nasal spine. And length of mandible from menton to gonion, here gonion. This very important for tracing of cephalometric. And here, as I explained, is the nasal bone. Of course, here the sutures between frontal bone and nasal bone is the point of nasion, N. And here the lowest border of the orbital margin is OR, orbital. This all cephalometric you need to check, and this one is the most important angle for us in treatment of anterior posterior direction, is angle we call ANB. This one, ANB, until here. This one gives you the relationship of maxilla and mandible in anterior posterior direction. This one actually is cephalometric. Very details. I think we need one lecture for cephalometric only, but I try to give you the most important structure now in this time. Okay, after this, if the patient have caries or have any tooth you can see treated, you must do periapical, because by panoramic and cephalometric you cannot get the details of apex area. For this reason, to be in safe side, for example, this case not indicated for ortho. This case already have abscess. You need to do treatment of endo very perfect. After healing everything, we can think about ortho after our bone will be healing nicely. Okay, now we go for dental history. Okay, here dental history not main thing to do here, but dental history you need to check the situation of TMG, how he opening his mouth, how the movement of mouth laterally, how he's clicking, pain, swelling during the examination of the condyle, periodontal problem, and oral health status. Okay, periodontal problem and oral health status. If the patient not good oral health status, he is not indicated for ortho. If he patient have periodontal problem, also not indicated for ortho. This what mistake we can see in many clinic. They do braces, important to take deposit from the patient money. After that, let's start immediately to do braces. They study maybe by courses, sometimes if they are not specialists, of course by YouTube or something. This one not indicated. Why? Because if the patient with his mouth without any braces, without any removable or functional appliance, he's already poor oral hygiene. How can be after? Because take care for braces and removal appliance, you need to take your patient carefully. You need to, for me in my clinic, if the patient come to me and he's poor oral hygiene and he need to do his appearance for some reason, I try to control him for 1 month. How his progress is okay. After that, if improvement and his gum already okay, and I see he's already take care for his mouth, I can start. If no, no need to start, because after braces, his oral hygiene will be much poor. Okay, medical history here also you need to check all chronic things, all a clinical disease, and you need to focus also for allergic and chronic disease. Epileptic attacks, for example, epileptic attacks, if he has a history of epileptic, not indicated for removal appliance, but fixed appliance can, because removal appliance need epileptic attack, he can slowing the appliance and blocking the breathing, the respiratory system. For this reason, you need to be careful for all these details of chronic and allergic. Also, this also allergic. Some of they have noise during the pollen, especially in summer. All allergic. Okay. Now we go for more dental things. This actually is the general things. We go for extraoral. I divided in my lecture based on extraoral examination and intraoral examination. Extraoral examination, this means we try to do examination before we open the mouth. And this one is skeletal examination. We call skeletal pattern. Anterior posterior direction, vertical direction, and transverse direction. I divided in 3 directions. Anterior posterior, this means from anterior posterior sagittal plane, vertical, and transverse. Okay. Soft tissue also here important, lips, tongue, and also cheek. TMG very important here. Why? Because TMG is our main things for occlusion to contact our teeth with upper teeth. Any problemity of the TMG, of course, effective for our occlusion. Habits, also habits. Habits and soft tissue for me is most important during diagnosis to take care very carefully. Why? Because if this patient still continue with his habit or continue with his soft tissue factor of etiology of malocclusion, after you remove the braces, the teeth will be returned back, relapse, and no result. For this reason, to avoid the relapse, many cases they complain, I did my orthodontic treatment, but unfortunately, after I remove the braces, the proclination of the teeth become again. This one because of diagnosis, wrong diagnosis. Because the etiology factor of malocclusion is still there. Before you start any treatment, you need to think about remove the factor of malocclusion. Okay, here actually anterior-posterior relationship of skeletal pattern. Examination of skeletal factor by cephalometric. As we mentioned, cephalometric is the best one to see the relationship of skeletal factor. Or clinical method, of course, if you can see the clinical method, now I show you in the next slide how to see the relationship of maxilla in your dental chain. Of course, anterior-posterior skeletal relationship clinically can be examined by palpation method from point A to point B. This is the method. The patient in your chair must be located in Frankfurt plane, his Frankfurt plane parallel to the floor. This is the Frankfurt plane. The lower border of the orbital to Borean is external auditory meatus, the highest point of external auditory meatus. This one is the line from here to his ear. This one is Frankfurt plane, should be parallel to the floor. After that, you try to do this one. If index finger applied to point A, this point A here, and point B is the middle finger. And always, if they touch both the arches, this means class 1. If they touch, see here, this one actually class 1, this one class 2, this one is class 3 because mandible is forward. Here is maxilla is forward. Here almost the relationship between 1 to 3 or 4 millimeter is acceptable to see the difference. Maxillary is anterior to the mandible. For this reason, here is class 1. If you apply this method of palpation of the finger, you can see if in this case will be both fingers will be touched for maxilla and mandible. This means class 1. Sometime in cephalometric, no need to do because already it's class 1. But here, if you put this finger palpation method, you can see here this index 1 will be touched, but the middle one will be not touched. This means class 2. Here, of course, touch the point A. For this reason, this one is class 3. This one is skeletal examination. Now, based on this profile of class 1, class 2, class 3, we can see different patient profile. This one is look like straight, is class 1. If class 3 will be concave face, and this convex face if class 2. Okay, vertical relationship of skeletal. Now I don't examine the dental, still in skeletal pattern. This vertical, you need to check is lower facial height, this one, this lower facial height, equal with middle facial height or no. In normal proportion should be equal. You can examine this one by mirror or by probe. Important to take the distance from here to here, from this area to Minton and from this area to Gonian area. Should be equal. If this one have open bite, of course you can see this more higher than this side. This means maybe open bite, sometimes cross bite or scissor bite. But if less than this proportion, this patient maybe have deep bite or short face based on the profile of the patient. This actually the vertical. Now we go also for vertical but by angle. This we call Frankfurt mandibular plane angle. This one is Frankfurt plane. This one is the mandibular plane. You can see this angle almost around 28. If open bite like this case, you can see this more bigger. This one also Frankfurt mandibular plane angle give you the relationship the lower facial height is high or normal or low. This one you need to think very carefully by this method or by this method, very simple also. Very simple this method to see the proportion of facial height. Okay, transfers. Transfers, of course, you need to check here is that skeletal. You need to check the symmetrical. Is the proportion of midline is right and left equal or not equal? Here, of course, the proportion of the face cannot get 100% is equal. Last time I have workshop in one in University Malaya, actually it's from Sheffield. One day he explained how to do the differentiation between right and left midline, this symmetrical faces. Based on his study, he said 80% of population is asymmetrical. If you go for details, examination, because by neck eyes, you can see no different. We can accept this in clinic. But for symmetrical, this one, for our clinical, we accept in by neck eyes. But this specialist of symmetrical and asymmetrical, they measure in millimeter every details in the measurements of the face. Of course, you cannot get 100% perfect. But for practical, we go for practical more. We need you need you to see how the differentiation between right and left side, this one. Okay, you can see this midline, actually. This midline. You can see my slide, yes?
Yes, yes.
Yes. Okay, this one you can see the midline. Almost this one look okay. This one you can see shifting. This one also shifting. This one shifting. This one, of course, shifting. This one already cannot treat by orthodontic. This patient needs orthodontic surgery. Cannot tear touch. This one also, if you can see development of mandible here, this all this one is skeletal shifting, skeletal asymmetrical, skeletal, because you can see from outside. Okay. Also, this George Bush, ex-president of America, if you can see this area, this side is the right side, is more different for right side. He is also symmetrical, but if you go by details, you can see he's symmetrical. But if you see him in the television or somewhere, maybe he's not normal. You can check in your chair all these details. Okay, now we move to soft tissue. What the most important to soft tissue? Okay, here I want to explain you important information. Always you remember. Our teeth in this situation, your situation now, my situation now in my mouth, our teeth is located in natural zone area. Our teeth located in natural zone area. This natural zone area equal in force between the force of the tongue and lips from anterior and cheek from lateral. This balance we call natural zone. And our teeth located in this position. Now, if our teeth move anteriorly, need to check your tongue. Maybe your tongue is big and make more force to move the teeth anteriorly and proclination. If your teeth is retrocline, or maybe you can think about lips. Maybe the tongue is small and the force of the muscle of lips is very developed and return back your teeth back. Same for posterior segment, premolar and molar. Related to the muscles of the cheek and related to muscles of the tongue. For this reason, natural zone is the most important point to check our position of the teeth. Now, our muscles of the lip, you need to check muscles of the tongue and muscle of the cheek. Because if your tongue is big, believe me, you have already open bite, is right? Okay. Or proclination of the teeth. You do braces. After that, everything okay. Remove the braces, already relapse. Why? Because it's still there. The reason of movement of still there. Now you need to evaluate the tank. Is the situation of the tank how? Situation the cheek, situation the lip. Why this reason of proclination? Why the reason of malocclusion? You need to know the reason of malocclusion. Without the know of reason, okay. But for example, one of the participant maybe has question in his mind. Okay, I have big tank, but I have open bite, but I need to improve. Okay, now this the experience of the specialist. He need to evaluate diagnosis from the beginning, and he need to write in the end of treatment in his file. In end of treatment, this patient is under fixed retainer. You need to explain the patient from the beginning. See, I can do for you ortho braces, but after I remove the braces, I will do from the back lingual side fixed retainer whole your life. If he's agree, you can start your treatment. Because if the soft tissue factor, the tank is big, believe me, you do braces, remove the braces, teeth will be back to natural zone. For this reason, fixed retainer to keep the fixed retainer from lingual side, from canine to canine, or from premolar to premolar, but always I do from canine to canine, if the patient is agree. But you need to discuss with the patient from the beginning. You are indicated for fixed retainer. This fixed retainer, you need to wear whole your life. Otherwise, your tank will be moved the teeth anteriorly. For this reason, this factor of soft tissue you need to take care for. Unfortunately, majority of orthodontics, they don't take care for soft tissue examination. The soft tissue examination, majority, 90% of relapse from soft tissue factor. Because here, majority of the, we have operation, of course, plastic operation to reduce the size of the tank, but nobody can accept this one. For this reason, improve the profile and keep the tank in the same size is okay, but you need to think for fixed retainer. This one you need to check from the beginning. And also the lips thickness. Okay, now evaluation of the lip. The lips consist of several muscles. The form and function can consider into plane. Okay, we have sagittal plane, and also we have vertical plane. The normal lips should be the maxillary lips, anterior to mandibular lips is 1 to 3 millimeter. This based on the base of the bone of our maxilla and mandible. This one is sagittal plane. Should be this one anterior to this one. Okay, now vertical plane. Vertical plane, the upper lips meet the lower lips to form the lip line. We call this one lip line. In normal, they must to meet in junction between middle and incisor third of upper interior incisor. This one is in the rest position. See, if you divided your upper incisor to incisor edge, middle edge, and cervical edge, must be to meet upper and lower lips in relax. Don't make the patient to move based on himself. You can see if he moves relaxed, you can see no tensions of muscles. Because if he try to make up or down, you can see the stretching of the muscles. For this reason, try to talk with him, relax, everything okay, swelling the saliva. After that, try to close slowly, relax. You can see if he in middle and incisor edge here in this area, meeting the labial line, upper and lower lips, this means normal. This one is normal. But if this lip line meet up, we call high lip line. If this lip line meet low than this line, we call low lip line. Now, I show you what is important clinically. It's very important to know the lip line of this one. If you want to see, now everyone can see me?
Yes, doctor. Yes.
Everyone can see my picture, is right?
Yes, yes. Your video is on screen.
Okay.
Yes.
Okay, nice. For this reason, we have normal lip line, we have high lip line, we have low lip line. This one is important in clinical. I try to give you now little bit information regarding to class 2 division 2. Okay, now if you can see high lip line is often one of the etiology factor of class 2 division 2 malocclusion. Anyone have this profile, incisor, central incisor, it's retrocline, and upper incisor brookline, this we call class 2 division 2 incisor classification based on the British Institute classification in 1983. This one, because before that, only angle classification divided class 1, class 2, class 3. But after this, British Institute classification of incisor, they divided class 2 to 2, class 2 division 1, class 2 division 2. This from 1983. Okay, this one, this profile, can see this one? This we call class 2 division 2. Always, anyone have class 2 division 2, you can see lip line is high. For this reason, when you treat this case, you need to think for retainer, fixed retainer from the beginning. Otherwise, you will get relapse because the lip line high. Why this one happened like this? Because you know, during the eruption, this the central incisor is erupted early, is right? After this erupted lateral. Because the high lip line, the force of lower lip and upper lip together make force to central incisor, and this central incisor during the eruption in the beginning, before they erupted the lateral, they make retrocline. When this one come to erupted, already space not enough because this one retrocline takes space. Brookline, we get space. When we do in orthodontic brookline, we get this space of retrocline of soft tissue, high lip line. This one go back and narrow will be narrow of our arch because the length of arch will be narrow. For this reason, this one will be retrocline because the high lip line, this is the main reason. And this one, when erupted, no enough space, he tried to go buccally or labially. Okay, for this reason, this one is the lip line important. Because if you don't check the lip line, especially for class 2 division 2, this one no need to check, already 100% is high lip line. But for low lip line also sometimes we can see proclination and sometimes of the problem of the occlusion. For this reason, soft tissue is important, and try to take care for every details of lips, tank, and cheek. Okay, this one actually we competent lips. This one incompetent lips. Why we call incompetent lips? Because if you see the patient try to close his mouth, but if you see the muscles is tension of the muscle. Because always people, when they only relax, you can decide this one competent or incompetent. But in normal, always have incompetent lip. He try to close, but he try to close by tension of the muscles. This one in relax is competent. For this reason, this one closed, this one is closed lips, but this one is we call competent, and this one we call incompetent because the muscles try the patient by himself, by his force. He tried to do this sealing of the lips. Okay, here the tank. Okay, of course, if the big tank will be proclination because the force of our tank internal of our oral cavity will be more than our lips. The teeth will be procline. The teeth will be procline. But if the lips is strong and our tank is small, our teeth will be retrocline. Procline, retrocline. Okay? How you can check is the tank is small or big or normal? Because our tank actually located in the oral cavity. If the tank is big, this means, what this means? This means not enough space in oral cavity. Now the tank try to have stamping of our teeth here. See stamping. This big tank, not enough sit in the oral cavity. In the border of the tank, you can see stamping, stamp of our teeth. See here, not straight border. We have regularity. This regularity is the form of our teeth. Of course, if tank is big, proclination. If small, like this, for example, see, we have myofunctional appliance inside the mouth and also still have space. This one we can see retrocline of the teeth, retrocline of it, because the force of the lips more than the tank. Okay, temporomandibular joint. Okay, here actually temporomandibular joint, I want to tell you this, the anatomy. This is the condyle process. This one is the disc. This one is the front temporal bone, of course, and this one is the mandibular fossa. Here, actually, this is the capsula of TMG, is synovial membrane, because synovial joints. This one actually auditory meatus here, external auditory meatus. This one is zygmatic arch. This masticatory mastication of muscles. This masseter, this temporalis. All these things, of course, we have here also ligament. We have 3 ligaments: sphenomandibular, temporomandibular. Okay, these all things. This one you need to check carefully by this way in this picture. Try to palpation the area of the TMG, and this palpation of area of TMG make the patient to open, close, lateral movement, right, left, and you can see if you have any pain, clicking, and swelling or anything. Okay, this is very important because TMG problem related to our occlusion. Okay, here is pain, sound. If you have any sound clicking or some things, you need to check. Okay, as you know, this one our TMG is right. This one our TMG. Our TMG is the medial between carnivore and herbivore. Because this one, if you see the tiger, dog, all the carnivore who eat the meat, this kind of TMG only allowed to open up down. Why? Because 2 reasons. One is prominent of canine. See how this and fossa also deep fossa. Up down only. Okay? This one carnivore. And another type of occlusion is herbivore. This one, cow, sheep, all this one. This one, when they eat by milking, the lateral movement is more developed. And the canine almost in one level for all teeth. If you see this picture, almost same level. No development of canine. Our TMG or occlusion is between them. For this reason, we can move laterally, but limited, not like cow. And we can go up, down, but not strongly like tiger. For this reason, our canine is prominent. You can see in the picture. But not that prominent like another carnivore animal. It's shadow milking. And the canine not prominent, cannot allow, because canine is the prominence of the canine is the key to prevent lateral movement. Okay, habits. Habits also now, if you have any questions for soft tissue, answer. Let's we move now to pathology factor, and we try to know all the habits of the patient during examination, like thumb sucking, lip sucking, tongue thrust, mouth breathing, all this one. I give you briefly what the importance of everyone. Okay, any habits actually have duration, frequency, and intensity. This general information. Duration means the time that frequency, the numbers he do these habits. Intensity, how the force. For example, some of them they do thumb sucking, but some of them they press more. You need to record. Okay, this is all the thumb sucking. Of course, thumb sucking, you have a lot of, you need to stop this to treat the patient for this habit before you start any treatment, because this one is make you open bite, can make you procrastination of the teeth, all these things. Okay, this one actually what I want to explain in this slide, this one is the phenomenon is normal, because during the infant inside the uterus suck his digit or finger with order to suck the immunic liquid to develop the digastric system is normal. This phenomenon sucking is continue after birth, because he also take the feed breathing or breast milk feeding. But this sucking continue after childhood is considered as bad habit. For this reason, after stop the breastfeeding, try to everyone in his level family try to control this one for thumb sucking, because this one later have a lot of problem of malocclusion. Okay, also this one is same during the sucking of the milk, feeding the milk, the tank will be moved anteriorly. This cannot control the tank, always they move the tank anteriorly, we call tank thrust. This tank thrust also, if you don't treat the tank thrust first, the treatment after you remove the braces 100% will be open again, because the tank will move anteriorly, give force for anterior. This actually the treatment of tank thrust for appliance, at least to make the patient to control his. Actually, I treat some patients, I think more than 5 in my life, tank thrust, but successfully. This one wearing almost around 1 year, some of them 6 months. And after that, adaptation of controlling his tank to me interiorly. This is the appliance. Treatment, tank thrust appliance, we call it. Okay, mouth breathing. Mouth breathing also is the patient feel when he need more oxygen, and the nose not enough. Of course, he try to open his mouth. This phenomenon will be or can be seen in lower and anterior position of the tank and lead to open bite and cross bite posteriorly, because imbalance between cheek and tank force. Okay, what affected for our growth and development of our maxilla, especially for maxilla during the mouth breathing. When the patient breathes from the nose, the air will go to the air sinus. This is our maxillary sinus. And this one, the area where go to sinus from our nose, we call osteum. This is the connection. If this close, already we have inflammation of epithelium here, and we have sinusitis. And when the air during growth and development enter by nose, of course, this air will go to sinus by this osteum. And will do what? Will do friction, the lining mucosa inside the sinus to humidify the air before going to lung. This friction of mucosa, one of the factor of growing and development of maxillary sinus. For this reason, long time during growth and development, the patient breathing from the mouth, he will be narrow maxillary arch, and also you can see V shape. Actually, this one you need to treat. Why? Because either the result of bad habit or big adenoid. If habit, we can treat. Adenoid, you need to send him to ANT. This, the doctor of ANT, he need to make him easy to breathe, because he cannot open his mouth if he can breathe by nose very nicely. Okay, now the air entering to the normal growth and development part of the face. This is what I explained. This what was the meaning. Growth is the increasing in the size. Development means increasing in the size with psychomotor and function. This you can see the patient with V shape, 100% this mouth breathing. You can see the development of the maxilla is less. Okay, clinically, maxillary sinus, as we know, we have 4 sinus. We have maxillary sinus, we have sphenoid sinus, we have frontal sinus, we have from inside is ethmoid sinus. But all these old sinus is small, is the cavity lining by mucosa or epithelium. This one, most important for us of this picture, because if you see the structure here, this osteum will connected our maxillary with our nose, where friction of the air here top premolars. Because the related the space between sinus and the teeth in millimeter, sometimes if you have inflammation in the sinus, patient he think bulbitis, he think some dental problem. For this reason, try to do this examination very well and see the situation of the sinus. Okay, intraoral. This all extraoral. Intraoral, we have dental examination, path of occlusion, labial segment, and buccal segment. Dental examination. Here you need to check the situation of the teeth, how the erupted, how the hygiene, all the situation of the teeth is very simple. Here, path of occlusion, of course, the patient, when he closes his mouth, if in normal, he can close up, down. But if they have a maturity point, not contact, he try to move to make contact to function of his mouth. For example, this one is contact perfect. But if you have any problem, patient try to move to contact. This one, after this we call habitual closure. He's not abnormal, but he's already adapted for this one. For this reason, you need to check in relax and make the patient open and close. Okay, this one, what I explained, of course, based on this can be displaced the mandible or forward to have contact, or backward or laterally. Forward. When the patient moves the mandible more forward position to allow mandible incisor to go labial to the upper incisor. For example, this one anterior crucifix. Of course, anterior crucifix, he cannot easy for him to cut in this situation. He tried to move like this to make little bit forward to make contact between incisors. Also, severe class 1, class 2. Severe class 2, like this case, for example, the patient always he see he's not comfortable with this situation. Always he try to move his mandible forward. This one is the forward for this some example cases. Backward, some cases, for example, what I explained, class 2 division 2. This class 2 division 2, of course, when he in normal position, he cannot contact. He tried to make backward to make contact. And also class 3. Class 3, like these cases, class 3, try to patient to make backward the mandible. Lateral movement. This one, I give you example, is crucifix. This one is the crucifix. Because in the normal, this cusp should be located here, buccally. But he located in the fossa or occlusion of the lower mandibular. This crucifix, of course, the patient tried to move because his abnormality. He tried to move his mandible to get contact, sometimes left, sometimes right. This we call lateral movement. Okay, if you see also some in reference, you can see Sunday bite. Sunday bite is forward movement. This patient, see, but if she put in the picture, she want to take picture or she want to meet someone, always she do movement of this mandible forward and she will look normal. But in relax, she is like this. This we call forward, or sometimes in some reference we can see the term of Sunday bite. Okay, labial. Labial segment. Now how to examine the labial segment. What you need to check here, angulation of the teeth related to the mandible or maxilla. Here, you need to check proclination of the teeth, normal or retrocline. This all. This one actually is normal. This one is retrocline. This one is procline. This one, if you see procline of the teeth, but if you see that the bone is normal. This one is class 1 relation. Okay, space in anterior segment. Now we are in anterior segment only. Later we move to posterior segment, buccal segment. You need to check the space. Okay, the distance from this mesial area, this mesial of the canine to the mesial of the canine should be equal the mesiodistal width of every incisor. In this case, if you see, this distance is more than mesiodistal width of incisor. Of course, we can get space. In this case, if you take the distance from already here, clear crowding, because this one mesiodistal width of the maxillary incisor, not enough space. For this reason, also canine is buccally, because canine is erupted early, because lateral incisor from anterior side already erupted early, and premolar 4 erupted early. When he erupted the canine, if small arch, of course he go or impacted or buccally or lingually, because he came late. Already space not enough. His space taken by lateral and premolar. First premolar is 4. Okay, this one you need to check. This one we call space discrepancies. Always we can see spacing between the teeth or crowding. This related to space. Here you need to think for treatment how to close this space, but for your information, during orthodontic treatment, crowding after treatment is more easier. But spacing after treatment more relapse, because you need to control the reason why this is spacing. Almost you can see the reason. If the tank is normal, you cannot do fixed retainer for long term. But if the another reason, you try to think in during the examination. Okay, rotation teeth. This one also rotation. You can see, check if you have any rotation. This rotation, this rotation. Sometimes we need to create space. Sometimes already we have space. Like this case already we have space. This one you need to create space. We can create space of rotation for orthodontic, always by proclination of the teeth if your lips allow. Okay, now labial segment in relation. This we examine first part in individual. Now in relation. Incisor classification. This actually the incisor classification was, I mentioned this one in 1983. Class 1, if the lower incisor edge located in the cingulum bluto of the upper incisor. This one is class 2, proclination all incisors. This one is class 2 division. Class 2 division 2. This one related to the position of the lateral incisor. If all is class 1 division 1, if lateral incisor is procline and central incisor is retrocline, is we call class 2 division 2. And this one is class 3 if this incisor edge of the lower located in anterior to the cingulum bluto of upper. Okay, this one overjet. Of course, overjet you need to check the distance, this distance in millimeter, of course. I show you. This is the ruler. You need to check in the millimeter like this and see how many millimeter. Of course, around 1 to 3 millimeter is normal. Overlapping anterior-posterior overlap of maxilla central incisor over the mandibular central incisor in millimeter. This is the distance between upper and lower. Okay, here in overjet, you need to think. You need to think very carefully. If you want to reduce 1 millimeter of overjet to return back, you need to have 2 millimeter space. 1 millimeter in this side, right, 1 millimeter in left side. Why? To keep midline same. To keep the midline same. 1 millimeter of overjet to reduce, you need 2 millimeter in each side, 1 millimeter. Okay? This one you need to retract, but to keep the midline in the center. Okay, overbite. The measurement of overbite, of course, by this way, you need to have marker here. And after that, you check the distance from this point until this point. This is the overlapping of the teeth, anterior teeth. Okay, here actually in the normal should be the upper incisor located in the middle part of lower incisor. This is normal, like this. This normal. But if located like this, already we call deep bite. If located like this, we call open bite. If this, deep bite. Okay, now here you need to measure by millimeter, if normal, or increase. But the same like this case, no need to measure. Already you write complete overjet. Complete overjet have 3 types. Complete overjet, complete with trauma of palate, complete of trauma of gum. because when you have this one is normal, when you have this one is deep, this one contact, maybe during closing you can have a insert trauma of the gum and also palate. For this reason, this one articulated like this as normal is nice for occlusion to be perfect. But deep one can be without trauma or trauma of palate here or trauma of gum. And sometimes if this one deep bite complete with retrocline of the incisors, we can also make, we can see here attrition of the lower teeth. Open bite, very simple, you need to check. But here, open bite, you need to think. What the reason of open bite? Before you start orthodontic. Because this one, in neutral zone, what we said, in neutral zone, our teeth is located in neutral zone. In neutral zone, if normal, this one open bite will not will happen. Will happen in two reasons. Or skeletal factor, this one not your business. Go to orthodontic surgery. Or habit, you need to stop the habit. Or soft tissue. Soft tissue, you need to think the reason of soft tissue and tell that to make fixed retainer in the end. For this reason, open bite easy to close. Braces, elastic, finish. This one, of course, this is the anterior cross bite. If 1, 2, 3 incisors located lingually, this one is called anterior cross bite. If all incisor like this located is anteriorly, we call class 3. But if one like this located lingually is class anterior cross bite. This anterior cross bite also you need to check how many teeth and the number of the teeth. Check the center line. Now center line of the teeth, not the face. Previously we checked the from extraoral examination, the relationship of right and left side. Now we try to check the midline of the teeth, because if you see this central incisor, this lateral incisor, central incisor, this is the central incisor. This line should be here. But this one is shifting of lower teeth to this side. The midline, see this one is the normal. Upper and lower should be equal in this midline. If this one located here, we call right midline, or here is left midline. Same for upper. Okay, why this very important? Because during examination, sometimes if the shifting of midline and you have crowding and shifting of midline, you need to check very carefully. In the area of shifting of midline, no need to extract. No need to extract, because you get space when you shift the midline. I give you example. Now, this one, for example, here the canine, if you see, is located mesially. And I need to make space for this canine, 100%. From where I can get this canine space? From here. Because when I extract here, I try to correct this midline to be here, and I get space almost around maybe 3 millimeters. Okay? Here. Because I try to move this one to be in the midline. And space from here, I can correct the canine. Sometimes shifting of midline make the patient to extract less teeth. But if the midline is normal and have crowning in this side, crowning in this side, you need to extract both. Okay? This one, very carefully for midline. Midline, sometimes to advantage for the patient. He reduce the number of extraction. Buccal segment. Buccal segment alignment. Generally, you will need to check if you have any angulation, you have spacing, crowding, this all for alignment. Okay, buccal segment in relation, this is the most important. Moral relationship, every one of us, 90s, 80s, 80s, 90s, 80s, 90s, start, developed. And this very old. And this classification only based on the key of occlusion, as he said, mesiobuccal cusp of the upper uh, uh, molar located in the mesiobuccal groove of the lower first molar. This, as Angel, he said, the key of occlusion. No, after that, they said many limitation and disadvantage of this classification. For that, his school, because he has now his student journal we call in orthodontic Angle Orthodontic Journal. His school, he said, they said no, he's the Nicholas, and he's the one who developed all this classification, and he's the first one who make this one. He cannot through this one his literature, because this one only explain class 1, class 2, class 3, and he don't give the separating. Is this class 2? Which class 2? Is mild, moderate, severe? No, because not numbering. Now, if you know, familiar, they developed recently, maybe the last 10 years, developed the modification of canine classification. Modification. This means this class 1, normal. But if class 2, moving in this side. If class 3, moving in this side. But based on the location, they said class 2, for example, if class 2, this one is full. But if located here, the mesiobuccal cusp here, we call class 2 half. If located in this side, quarter. If located in this line, is 3/4. This all the classification of angle. Now they move from quantitative to qualitative to quantitative. Okay, also canine classification, same. This one is the class 1, is the normal, is this one class 2, movement anteriorly, this one is class 2, movement buccally. Okay, present of any posterior crossbite. This one is horizontal. This one actually crossbite when the buccal cusp of maxillary teeth occluded lingually to the maximum height of the buccal cusp of opposing mandibular teeth. This one is the crossbite. This one is the crossbite. But you can see we have in crossbite 2 types. We have unilateral, we have bilateral of crossbite. In normal, should be this one, as mentioned in this one, buccal cusp of maxillary. This is the buccal cusp of maxillary, included lingually. This means already lingually, because in the normal should be located here, buccally. And this one is abnormal because crossbite. What's the meaning? Caesar bite is the opposite. When this one lingual cusp is located buccally. See, this teeth already outside the arch, especially this the cusp, lingual cusp. This we call crossbite, Caesar bite. But this one, if you see, is the inside. This means crossbite is narrow arch, crossbite is widely arch. Okay. Also open bite posteriorly, this segment, posterior segment, you need to check if they have and measure, and you need to know the reason. Now, here I show you some of the pictures. Okay, I go one by one. I share with you, because I know this one only diagnosis, but I share with you, this one is the anterior crossbite. See the treatment and see the patient already happy after treatment, and this one already after treatment. And everything okay after, I think already more than 7 months, already she is no any relapse. Okay, this one also simple case, buccally movement, and this one is the result. This one, see the crowding, upper and lower, patient already happy, smiling here. And maybe later, this one is the most important diagnosis. Treatment and planning of treatment related to diagnosis. Later, if we have time, maybe we can go for more treatment. How to treat class 1, how to treat class 2, how to treat crowding, how to treat this one. Okay, this one, but later if we have, we can discuss with our friend, Dr. Ghassan. Okay, but not now because the time is very crowded now. Everyone busy, and also we have a lot of things. For treatment, I think we can share more information and we can share many types of methodology of treatment. If you see here also crowding with shifting and the patient already okay, this is the case also upper and lower crowding and also propionation, this one closed loop and already the result you can see here. Here also the diastema. Why this I show you this picture? The diastema cannot start without remove the reason. The reason what here is the frenum. You need to do frenectomy by surgery to remove the reason of this space. After that, you can close the space, no relapse. If you do any braces in this situation, after you remove the braces, the connective tissue of the frenum will be open again. This also some cases after treatment, and this study model before. See this one, how the increasing of overjet, but alhamdulillah, we get nice result because we make maximum anchorage. We use all 7 millimeter to move the anterior teeth buccally. This case also, you can see very narrow arch, and you can see the teeth crowding, very severe crowding, and already she is very happy and okay. Also this case, if you can see, facing here and also creasing overjet, and the end she is already smiling, okay. This also class 2, you can see the difference now between arch and study model. This also severe crowding, upper and lower, very severe crowding. I did extension of the arches and also extraction because the arch was very narrow and the end is okay. And this one also some cases for treatment. This is my thank you for attention and any questions. I hope you are already not sleeping like this picture.
Thanks a lot, Professor Rasheed.
And this is my email and many email if you want to share any cases with me for treatment plan. I will be happy to support and help anyone.
Thank you very much, Professor. On the behalf of our college and university, we are very grateful for this opportunity to have you today. It was very valuable information actually and elegant presentation. Very nice. Thank you very much.
Welcome, welcome, welcome.
I think our Dean, Dr. Ali Hassan Murad, is with us. If he has any comment, Dr. Ali?
Naam, Dr. Ghassan. Thank you very much, my brother and colleague, Dr. Rasheed, for this. We were together among the founders of the College of Dentistry, University of Damar in Yemen, and he was one of the most prominent teachers I know. Again, I thank him with my great appreciation.
Welcome, welcome, brother.
Also, I would also like to thank the president of the Al-Qadisiyah University for his permanent presence and personal follow-up to this lecture. So it's welcome at the College of Dentistry. Dr. Rasheed, please, I have one simple question.
Yes.
As you know, in the basic treatment of in ortho, in the past, they told us that the best time to treat the teeth orthodontically is about 12 years old. The question, is this still the same?
Okay, this means your question, when you can start orthodontic treatment, is right?
Yeah.
Okay, nice question. Actually, this always...
I ask about the advanced technology.
Okay, advanced technology.
Can you start now at any age, or is the best like the past 12 years?
Okay. From my experience, you can start orthodontic treatment, but we call interceptive orthodontic. We can start from between 8 and 9 years old, only for serial extraction. This serial extraction to make extraction of the primary teeth to expectation if they have crowding, to avoid the case to be crowding. One. Second, this one from 8 to 9. Also, you can start if the patient have anterior crossbite. Because if you have anterior crossbite, this one easy to do, or class 3, try to do immediately to make the relationship of upper and lower very early. This one between 8 and 9. Also, myofunctional appliance. Myofunctional appliance here, we do very early, but we need to continue for to use at night only until maturity to prevent the relapse for myofunctional appliance. Because myofunctional appliance, we try to make stimulation of growth of the bone, because after maturity, when he's already baligh, the patient already blew. After this, we cannot after maturity, we cannot move the bone because the growing of the bone starting slow already, and some of structure already close of growing. For this reason, in this age, you try to make stimulation by myofunctional appliance. Actually, myofunctional appliance indicated for only mixed dentation and also only before maturity. You need to know what's the case, because some case now I see immediately for removal appliance, they do fix appliance and very early age. Sometimes still the root not fully formulated, and the root not fully formulated, and you start to apply force to move. Of course, this will be effective for formulation of the roots. For this reason, my answer to you, you can start between some patient 8.5 to 9, 8.5 roughly, and 9. You can start this one only for some things, for prevention, to do some things to reduce the severity of malocclusion in future. After that, every case individual decide. But functional appliance here is much important to make improvement of the relationship of maxilla. Because if the dental factor is the dental factor of malocclusion, this is not a problem. In the adult, after maturity, you can do braces, because braces can move the teeth. But if this one skeletal factor, for example, like class 3 or class 2 severe, this one after maturity, you cannot do anything by orthodontic. Only orthodontic surgery to help the patient to change him from orthodontic surgery to orthodontic. At least you need to do some things during this age. For this reason, your answer based on the case. But you can start from 8 to 9 years old for many types of different of the cases.
Thank you, Dr. Rasheed.
Thank you very much, Dr. Ali, for this comment. The audience, if you have any question, you can raise your hand and start the question. We will start with Abdul Kabir Yahya Imam. You can unmute your mic and ask the presenter. Abdul Kabir.
Assalamu alaikum, Prof. Rasheed Abdulsalam.
Alaikum salam.
Alaikum salam.
Yes. Thank you very much for the presentation. It will thrill you that I'm streaming live, listening live from Nigeria, northeastern part of Nigeria. So I have a question, a few questions actually, and probably a request after questions, please. One of the questions was what the last person spoke about the age at which orthodontic treatments should commence, especially especially at the current state. But I believe what you spoke about now was done justice to to that question. Secondly, do we have any what role does other investigative procedures, other investigative techniques such as CT scan, MRIs has in orthodontic diagnosis and diagnosis of orthodontic procedures? Do we have anything to do with such other investigative procedures? Then the request I said I have is I don't know if we can have access to your presentation, because some of us, because of the timing that the presentation had, we were online. After some time, they said they had to move it to 7 p.m., which we had a little time challenge again. So I personally, I got into the presentation, I think about 10 to 15 minutes late before I started following. So if we could have access to the presentation, I would actually love if I can get a soft copy of the presentation. So if I can get a link to hook up with the presentation, I would actually love that,
Okay.
sir. Thank you very much, sir.
Okay, welcome. You are from Nigeria, is right? Okay.
Yes, I'm from Nigeria.
Actually, Abu Bakr, actually for your question regarding to this one, I think the Al Qadisiyah will put the link for video because they're recording this one. You can put, you can see. Maybe they put in YouTube.
Yes,
I don't know.
we will try to publish it on YouTube very soon. Okay.
Okay, this one you can for orthodontic we can use all the investigations what you need, but when we need also, if you see in my presentation what I said, cephalometric, already cephalometric, I said not all patients. Why? Because this one is more costly for the patient and also more radiation, because X-ray is radiation. If the patient he don't need to use skeletal problem relationship of upper and lower arch like this is class 1, no need to do cephalometric. Why? Because the panoramic is enough to see all the structure of bone if they have any porosity or osteoporosis. For this reason, if the patient have pathology, if the patient have any shadow in X-ray, and you can, of course, you need to go for another investigation. But this one, individual, Abu Bakr. Okay? Okay.
I understand, sir.
Welcome.
Thank you very much, sir, for the
I
presentation.
I hope I answered your questions.
Yes, sir, you did. You did actually, sir.
Thank you, Abu Bakr.
Thank you a lot, Abdul Kabir Yahya Imam. Thank you for this question and for your comments. Our audience, if you have another question, please. You can unmute your mic and start to question the presenter. It seems there is no more questions.
السلام عليكم.
وعليكم السلام. أهلا دكتورة، تفضلي.
Good evening. Thank you for this nice presentation and nice topics. Thank you, Dr. Rasheed. I have a question actually. Although I'm not an orthodontist, but always I ask, what's the perfect time to get consultation from the orthodontics? You said from 9 to 10 to start with serial extraction, maybe earlier. But what if we have a crowding? What we have to do? Like, what is the perfect time to take our kids to the orthodontic clinics and get his consultation?
Okay. This one?
Yes, thank you.
What is your name, sorry?
My name is Lamia. Lamia Azzawi.
Okay, Lamia Azzawi. Okay,
yes.
Okay. Thank you.
Yes.
Thank you.
Actually, you have a very nice presentation and very informative topics, and you are a very good lecturer. Thank you very much.
Thank you, Dr. Lamia. I am very glad to hear this one from you. Okay, Dr. Lamia, see.
Yes.
Actually, here in Malaysia, the child must check with the pediatric. because we
Okay.
cannot, the only pediatric they check the child, because we have department based on the age and based on the department. And this one actually, the pediatric, he will decide if he need consultation with orthodontist.
The situation in EWAC is different because sometimes we don't have this periodically visit to the dentist, but sometimes like the normal people ask, my child is 10 years old now. Do I have to take him to the orthodontist? Yes. Because he has a crowding.
I tell you.
So we have to go to.
I tell you.
Yes.
When you need to think, when you need to think to take the child to orthodontist, because in the beginning, especially between this age, 8, 9, 9.5, this one, maybe the orthodontic can do some treatment without any appliances. I tell you, the patient have already crowding, okay? When erupted already lingually, buccally, this means not enough space because of this one. The doctor of the orthodontic, he can do serial extraction. This serial extraction one, for example, I give you example. First of all, erupted this one, okay? This first of all erupted the central incisor, is right?
Okay.
This central incisor when erupted is normal. Sometime go buccally, lingually, or rotation, we extract this lateral, right? And central incisor will keep in the place because already enough space. We extract this one. We call serial extraction. Okay. After this, lateral starting to erupt it, is right?
Okay.
But the deciduous canine is still there, is right? We try to extract deciduous canine early, and the lateral will be aligned. This means all the four will be aligned, normal.
Okay.
And later, the first premolar will erupt it before the canine, is right?
Yes, of course.
We can see already no space for canine because already we take the space of canine for this one, is right?
Yes.
We try to extract the first premolar because already with treatment, without treatment, first premolar will extract later, is right? You try to extract, now you extract the lateral to get space for central. You extract the canine, premolar, primary to get space for lateral, and later when erupted the.
طبعا دكتور لو اسف على الازعاج. بنهايه المحاضره كلش حلوه قاموا يقولون يا من نيجيريا من الاردن. اذا انا شفت بدنا نقاطعه بس صاحبي قال دكتور لا شوي انتظروا.
لحظه خلينا نخلص مع الدكتوره.
Sorry for interruption. Sorry.
I know, but if you change the time because of Ramadan, they communicate with me from Saudi, from Jordan, from Egypt, many. Maybe in different time in the normal life will be more participant interesting. Because now Ramadan, I know all they are lazy. Okay, interesting, doctora. Now you
I'm with you.
You extract lateral to get space for central, but this also deciduous. Don't extract, of course, the permanent. You extract canine primary to get space for lateral. Now, when canine erupted, already for there. When you start, you can see canine starting erupting. You extract first permanent premolar, and you can remove this crowding. Because when you can expect the child for this crowding, if he's crowded, one, if his arch small, second, third, if the space between deciduous not there, because normal child should be have spacing.
Okay, I understand now. Thank you very much.
Okay. For this
so
reason,
still, you are still with the school of serial extraction, because some of the dentists nowadays, they said we stopped doing serial extraction. I did it for my both daughters. So you are still with serial extraction.
Serial extraction actually prevent the braces.
Okay.
Because see,
okay, thank you very much.
See, from your experience, maybe you are a dentist, have experience. See how many patients with serial extraction they are developed very nicely and no need to use the extra.
Yes, this is what happened to my daughters. They don't need orthodontic appliance. I did for them serial extraction in University of Baghdad, and both of them they did great. But I heard some of my colleagues they don't use serial extraction anymore. I am not updating with ortho also. So just I need your opinion.
Maybe for financial part they need money from you.
Okay.
Maybe they need to pay money for braces.
Oh, okay. Okay, thank you very much. This is a business. This is very much.
No, actually, serial extraction is indicated especially for crowding. But for increasing the growth of maxilla of mandible, functional appliance, very nice. Monoblock, very nice. Stimulation the growth because you change the patient from severe malocclusion to mild malocclusion, easily to treat later. You prevent him from maxillofacial surgery because this one, and also you can use fixed appliance around 12 years old. I have. You need to use you need to do X-ray and don't do any force for root formulation. Because if you apply force in the root formulation, sometimes we use the braces, for example, for incisors, but we pass to 6. We don't put in the premolar like this. We call pass technique.
Oh, okay. Thank you very much. Thank you very much.
Or by remote appliance, finger spring, Z spring, Adam Class.
دكتور رشيد please.
Yes.
السيد رئيس الجامعة يحب يرحب بك يعني هو حضر موجود معنا
من بداية المحاضرة. من بداية المحاضرة ولا
لا اجى بعد 10 دقائق.
بلا خلاص إذا هو حاضر نعيد له المحاضرة.
هو يحب الكلمة كلها.
يا دكتور علي حسن نعيد له المحاضرة عشان خاطره.
الله يحفظك.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته.
ورحمة الله وبركاته.
السلام.
طبعا من الشكر أجزله ومن الثناء أوفره إلى السيد المحاضر الأستاذ الفاضل من ماليزيا، وأتمنى له الألق والمزيد من الألق العلمي والسمو والرفعة لجهوده المبذولة في إقامة هذه المحاضرة اللي تعبر عن أفكار قيمة. أنا ترى صراحة أكثر من 3-4 ساعة شفتها واستمعت إلها، وأتمنى من هذا الأستاذ أن يديم هذا التواصل معنا، وأن يكون في الريدة أن يكون ممتحن خارجي لطلبة الماجستير وأطاريح الدكتوراه في جامعة القادسية، ونتمنى أنه هذا العطاء يستمر ويانا والتواصل ويانا من خلال تبادل الخبرة وتبادل الزيارات، وتمنياتي له بالشكر والتقدير وقبول الطاعات في شهر رمضان.
شكرا.
والشكر موصول أيضا لعمادة كلية طب الأسنان والقائمين على هذه الورشة، ولهم مني كل التحية والثناء والشكر.
أستاذ الدكتور كاظم جبر القبوري، حياك الله. أنا أشكرك الدكتور رشيد عبد السلام المقطري، أشكرك جزيل الشكر على المقدمة الجميلة الذي فعلا أنا أعتبرها وسام في صدري، وإن شاء الله نكون في تواصل، وهذا شرف لي إن أنا أكون مشرف على طلاب الماجستير والدكتوراه في جامعتكم الموقرة، وأنا سعيد جدا إنك حضرت المحاضرة، وفعلا هذا يعني وسام في صدري.
الله يبارك فيك.
حياك الله.
شكرا جزيلا دكتور كاظم، الله يحفظك.
شكرا لكم.
الله يخليك. دكتور غسان. الو دكتور غسان.
اسمعك دكتور علي. الان
شوف
اذا اكو اسئله اذا هاي تواصلوا ويا دكتور رشيد.
Our audience, if you have any question, any further comment about this lecture. Doctor, about the diabetes mellitus, I am not a dentist, I am a physician, actually an internist. You say that there is multiple medical diseases have an impact on the orthodontic treatment. One of them diabetes mellitus. What is the impact of diabetes mellitus on the orthodontic treatment? In a brief, please.
Actually, if you see in medical history, I said we must to take care, especially for chronic disease and also for allergic and epileptic attack. This one is the most important. Let's we go one by one. Epileptic attack. The patient, when he has this situation, he can swing the glass. And this one,
Sorry, there is some technical error. I think the sound is not so clear.
You
Yes.
can hear me? This one actually, the first one for chronic and also the before is our patient have all symptoms to that capillaries and arteries, especially you can see now they are in and disease, no problem. Of course, in this area, you can make the improvement that if you treatment can be because you cannot do it. Understand?
Doctor, I think there is some technical error. The sound is not so clear. Was an interruption in the sound. I am very grateful for your comment and for your explanation.
Okay.
Our audience, if
You heard me about Mike.
Actually, I don't. The sound was not so clear. There was an interruption. The sound is not so clear. I think the problem is my internet connection.
You heard my answer. You heard my explanation. You need me to repeat. I can repeat.
In brief, if you can, we would be grateful, Doctor. If you.
Okay. Actually, as what I explained, the chronic disease and diabetic will affect our capillaries and because if the patient have diabetic, this means you can do braces and you can do full treatment, but you need to control the blood sugar. Otherwise, the removing of bone during the movement will affect it. If no diabetic, you start to move the teeth from the position, the teeth will be mild. Why? Because
دكتور رشيد بليز. اعتقد المايك بعيد عنك، صوتك في صدى كبير.
صدى كبير. اوكي.
هو يعني ضعف بالانترنت، اعتقد مشكله نت هاي.
اول كان افضل.
المايك بعيد عن فمك اعتقد ويعمل صدى قوي.
اوكي الان.
ايه ايوه الان شوف.
افضل.
تمام، كان بعيد عليك المايك.
اوكي. ايش what I want to say here. I want to say here in diabetic or any chronic disease will affect our whole system. And for orthodontic, it's important to check for the why? Because the patient is indicated for ortho, but he needs to control his sugar and he needs to internal motivation to control his sugar and to take it. Otherwise, during the teeth, because we move the teeth, forward, you have theory of movement is remodeling, means bone from another side to have new bone and make remove here. If the patient has diabetes, this bone to remodeling, and sometimes during movement you can get the mobility. For this reason, chronic disease, especially diabetic, the patient should be under observation, and before you start, try to make 1 month, 2 months to come to you to check his blood sugar. He's this one, he's take care for himself or he's not careless. If careless, no need to do anything, because otherwise you get mobility teeth during movement. Okay, Dr. Gassan?
Thank you very much. Well explained, doctor. Thank you very much.
Okay. I hope I answer your
yes, you answered very well. Thank you very much.
Welcome, welcome.
Our audience, if there is another question, please, you can ask. It seems there is no more question, Professor Rasheed.
Okay.
At the end of this session, we are very thankful again for Dr. Rasheed for his time, and we wish to have you again in another lecture, in another workshop in the near future, because we need a lot of information. Our students need this information, especially in orthodontics, and we would love to have you again in the near future, by God willing, inshallah. Thank you.
I hope, Dr. Gassan, I hope we share today our information, and I hope everyone value for him this information and also enjoyed the time.
I am sure they are. I am sure they are. Thank you very much.
Enjoy.
Inshallah.
Everyone enjoy.
Thank you for our attendees and participants. Thank you very much for our attendees and participants for their question and for their comments.
Okay, and my email actually is here. If anyone want to share for some cases or consultation, let's communicate. I prefer, or I have 2 emails, but I prefer Yahoo one. If you have any inquiry, anything, I am very very proud to share all information for anything for orthodontic.
شكرا جزيلا دكتور رشيد. شكرا جزيلا.
حياك الله. حياك الله.
حياكم الله. Our audience, if there is, we will end at this.
يلا مع السلامة.
شكرا جزيلا دكتور رشيد. شكرا للحضور الكرام. نلتقيكم إن شاء الله في نشاطات أخرى.
Okay. I receive. Okay, inshallah. Dr. Gassan, actually, I received some message from some people. They said they cannot enter. I don't know why, but they said if you have link of saving or recording, please inform.
It is now on my computer. I will publish it on YouTube and give you the link to share it.
Okay, inshallah.
Inshallah. شكرا جزيلا.
Okay, thank you.
شكرا مرة أخرى لجميع الحضور.
Thank you, my brother. Thank you, my brother, Dr. Rasheed. Thank you very much.
Thank you.
شكرا للجميع في أمان الله. مع السلامة.
مع السلامة في أمان الله.